Okay, looks like it's just about 3 o'clock, so we'll get started. Good afternoon, and thank you for joining us for our third session of our TBI webinar series. Today's session is titled Prognosis in Severe TBI. And we will get started with just some housekeeping logistics. So in order to earn your CE credits for this session, you must attend the session in full, so the entire hour. And then you also must complete each of the 3 poll questions that will appear throughout the session. So just answer, they don't have to be right, but you must submit an answer for those questions. If you have any questions or concerns about CEs or anything else, you can contact me, paige.grogan@cariskpartners.com. And then any questions for Dr. Spalding throughout the session, please submit them through the questions or chat feature, and we will get to questions at the end. Now I will pass it over to Dr. Spalding to take us through the presentation.
Thank you, Paige. I'll just do a real brief introduction of myself while we're waiting for a few more people to join. So I'm a physiatrist, so physical medicine and rehabilitation is my specialty. And I'm also board certified in brain injury medicine, which is a subspecialty of PM&R. And I've worked, my first year out of residency, I worked as a primary treating physician in an occupational medicine clinic at Kaiser in Northern California. And after there, I worked at the UC Davis Medical Center in the hospital-based service. So I worked in consults in the ICU, seeing patients alongside neurosurgery and trauma, and that's kind of how I came to this this topic for today. And I just sort of showed up in the ICU early on when I started working at UC Davis, and I said, you know, I hadn't actually been trained in how to prognosticate severe brain injury in the early days in the ICU setting, but it was I knew how to care for them beyond that, and I knew what life was like living with a brain injury, and I just sort of felt I could be helpful in those early days. And so I went to the trauma director, I went to the neurosurgery directors, and I said, can I just start showing up? Can I just come to rounds and be a part of what you do here? And I don't know how, but I feel like there's some way I can be helpful. And they were very kind and welcomed me into their ICUs and said, yeah, definitely. And I remember a conversation I had with one of the neurosurgeons, and he said, you know, we don't really know either, you know, early on. We don't know how to prognosticate severe brain injury early on. And, you know, once you start doing this work, eventually you're going to be the expert in this. And I was like, okay, so I better learn, you know. So I spent a lot of time and effort teaching myself, learning, attending conferences, and reading about how to prognosticate severe TBI. And it's challenging. It's not like spinal cord injury where we have, you know, your exam at 72 hours for spinal cord injury gives you really good clarity of picture of what life is going to look like for that person down the road. But with brain injury, we don't have anything like that. And that's really what this talk is about, is what do we know in the early days, and how do you talk about things when you don't really know what to say. So that's kind of what we're going to go through. I'm going to start with a case. So I'm going to basically present sort of 2 cases as we go along of patients I followed in the ICUs. And this one, the first one, was a 31-year-old man who was hit. He was driving his vehicle, and his wife was in the car with him. And a big rig wheel blew up on the other side of the freeway and flew across the center divide and hit his windshield, and came through the windshield and hit him on the left side of his face and head. And so in the CT scan here, if you can see around, are you guys able to see my cursor, Paige?
Yes.
Okay, perfect, thank you. So this, what we're looking at, is a cross-section of the brain. And here you can see these are the eyes, so that the eyeballs or the globe of the eye. This one you can see is not a regular round shape because it's been ruptured and broken. This is the eye socket here, and the white is the bone. And you can see here it's fractured, that the eye socket has been fractured. This is the brain tissue itself. These would be the ventricles, but as you may be able to tell, it's not symmetric. So what would be the middle from the nose to the back of the skull right here, it's shifted over. So that's the midline shift, where the midline, what this little line right here between the 2 ventricles should be right in the middle. It's shifted over because of all the damage to this side of the brain that's caused swelling. This is blood. This is a subdural hematoma right here that's pushing, and then the swelling in here is also the diffuse cerebral edema is also pushing that brain tissue over. So very significant impact, highway speeds, projectile right to the left side of his face. We'll come back to him later on throughout the talk, but that's just to introduce him, and we'll go through that. So he definitely had a severe TBI, and the definition of severe TBI, I'm not going to go through it as much detail as I did in some of the earlier talks, but just to revisit it briefly. So he had the Glasgow Coma scale for the severe TBI. The definition, it would be presenting Glasgow Coma scale of 3 to 8. With an altered level of alteration of consciousness that's at least 24 hours. He was in coma and had loss of consciousness. So greater than 24 hours would be of loss of consciousness is the definition for severe TBI. And post-traumatic amnesia greater than or equal to 7 days, and with imaging abnormalities. So these are sort of the definitions for severe TBI, but you can tell, you get a patient who looks like that, who's in coma, who has fractures, is bleeding in his brain, swelling in the brain tissue, definitely a severe TBI. I just wanted to briefly remind us of the Glasgow Coma scale. I'm not going to go through all the categories of it, but I just want to differentiate it from the Glasgow Outcome Scale, which we're going to talk about later on. So I just wanted to remind us briefly what the Glasgow Coma Scale is. It's basically how responsive is a patient. Are they in coma or not? And it's how they respond with motor function, so how they're moving, how they respond with verbal function, so are they communicating and speaking or not, and whether their eyes are opening. So that's the Glasgow Coma Scale, just to put that in our minds, and then we'll come to the Glasgow Outcome Scale a little bit later on. So we talked about imaging abnormalities for severe TBI, and I wanted to go through some of the different modalities, the types of imaging options that we have. So CT scans, the image I showed you of the patient was a CT scan, and it's really good at detecting gross blood, so new blood, large amounts of blood, things like epidural hematomas, subdural hematomas, subarachnoid hemorrhage, intraparenchymal hemorrhage, which is inside the sort of the meat of the brain, and intraventricular hemorrhage if there's blood inside the ventricles. But it's not as good at detecting microbleeds, so little small amounts of bleeding are not seen as readily on CT scans. For that, we typically use MRI. So MRI is really where you see the diffuse axonal injury. And we've heard of diffuse axonal injury a lot, and really what it is, it's, although diffuse is in the title, it's not specifically diffuse, meaning it affects all cells of the brains as a whole. But the axonal part means it's the axons, so the parts that connect one brain cell to another are the axons, and it's an injury to those axons which carry information that allows different parts of the brain to communicate with each other. And there's sort of different schemes of grading diffuse axonal injury, or DAI, but there's some variable utility to these, but just to give you an idea that there's different grades, and these different grades have to do with where in the brain that DAI is, and with the idea that it starts in certain places. So grade 1 would be a less severe DAI, and that would be up higher in the cerebral cortices, typically where the gray matter and the white matter interface. So the white matter is the axons. The white matter, it's white on cross-section actually, because it's surrounded by myelin. So myelin is a fatty tissue which looks whiter on actually anatomical view. And the gray matter is actually the cell bodies that don't have myelin around them. So where those connect, and it's really the axons, or the start of the axons as they start to connect to other cells around the brain. Grade 2 diffuse axonal injury is involving the corpus callosum, which is the part of the brain that connects the right and the left hemispheres, and where those communications go from the right to the left side. So it's a small area, but it's very important in terms of communication across the brain and overall brain functioning. Grade 3 would be considered sort of deeper damage down in the brainstem, which is sort of lower down in the brain, the older parts of our brain that have to do with functions like respiration it's again a small area, but many important things go through there. It's sort of the main highway between the brain and the spinal cord. So it's all the motor function, the sensory function that's connecting between the brain and the spinal cord all travels through that area. So the depth of DAI, so basically how severe and how deep DAI is present in the brain, correlates with a poor outcome. And that for example, if you have just a unilateral, so one-sided brainstem lesion, then you'd have an 8 times likelihood for having a poor outcome from that brain injury. Whereas if you had a bilateral brainstem lesion, so both sides of the brainstem show signs of DAI on MRI in the early days, then your odds ratio jumps up to 182 times more likely to have poor outcomes. So and DWI abnormalities, which are the things that you can see, DWI is diffusion weighted imaging. They're more common if you have hypoxic or ischemic injury, so lack of blood flow to the brain. And that can happen in association with a traumatic brain injury. So it may be that there's a traumatic brain injury and also chest trauma, and they've had a cardiac arrest and they're not perfusing their brain well because the heart's not pumping well. Or it could be that they have other vascular trauma and they're bleeding out and their blood pressure is dropping and they're not perfusing their brain well, and they can have an anoxic or hypoxic brain injury also in the setting of trauma. And a lot of times those anoxic brain injuries aren't actually recognized early on because the trauma is so severe. Now, I think we have time for our first poll question.
Yes, so I will launch the poll question now, and just a reminder to anyone who joined late, you must complete the poll question in order to earn your CEs. So I will launch that now. And we'll give everyone a minute or so to complete.
Yeah, and so just to talk about it while you're finishing here, there, which imaging modality shows evidence of DAI? And it's really the MRI, because on CT scan you're not going to see those microbleeds that damaged. So you really need to have done an MRI. And a lot of times early on they can't get an MRI for whatever reason. And so sometimes you don't actually see the full extent of the severity of the brain injury from just the CT scan. So Paige, you think we're ready to move on?
Let's give it a couple more seconds. It looks like about 83% have voted.
Okay, perfect. If anyone else wants to complete the poll to get the CE credit.
Okay, I think that's about it. So I will close this out and we'll continue.
Okay, great. Okay, so anytime we talk about severe traumatic brain injury, I have to talk about disorders of consciousness. It's a category of describing what people look like in sort of coma and emerging coma. And again, I went into this in a lot of detail in the earlier talks, but I wanted to just briefly mention it to remind us about what that looks like. So when people are in coma, they're unconscious. There's no awareness of their surroundings, no ability to communicate or interact. And there's no sleep-wake cycle. If you were to look at them in their bed, you might think that they were asleep because their eyes are closed and they're not interacting. But when you put EEG electrodes on, you don't actually see signs of sleep brainwave activity. They're not brain dead, so there is brain activity happening, but they're not conscious and not aware, and they don't respond to any kind of stimuli around them. The next level, as they're starting to come out of coma, would be called a vegetative state. And this is according to the brain tree stages of neurologic recovery. The vegetative state is a state of wakeful unconsciousness, which is a very confusing state for many people, especially family members, because they now appear to look awake. So they'll have periods of time where they look awake, their eyes are open, they appear to be looking around the room. If you do EEG assessments on them, you see that they are showing signs that their brainwave is looking awake. And then there's times when they look to be asleep, both clinically by looking at them with their eyes closed and on EEG. So you have the return of this sleep-wake cycle, but it's really a reflexive sleep-wake cycle. They're actually still unconscious. So they still have no awareness of their surroundings and no ability to interact or communicate. The next level is when that starts to return. So you actually have return of consciousness in the minimally conscious state, which is starting to have awareness of their surroundings, ability to hear and understand and interact, and starting to communicate in whatever way they're able to. But it can be really challenging, as you might imagine, to determine between the vegetative and the minimally conscious state. So there's about a 40% misdiagnosis between those two states. And that can get better with training, but even people who are really skilled at determining the difference can still have a hard time. So I just wanted to take a minute and introduce our second patient to you guys. So he is a 52-year-old male who was actually a work-related injury. He was hit in the head by a 2,000+ pound piece of logging equipment. And it took him 2 hours to be extricated, in part because he was sort of in a remote area, and in part because if they had this large piece of equipment they had to move to be able to get to him. He was intubated in an outside hospital and transferred by helicopter to the UC Davis Medical Center, where I met him. On arrival, he was bleeding, he was hypotensive, his blood pressure was low initially, but he got transfused and his blood pressure had come up to normal range of 129 by the time of admission. But he had a low heart rate and normal oxygen levels. His exam was interesting because in the Glasgow Coma scale, he was a 7, in part because he was moving. So the left side of his body would actually move and localize to pain really well, but the right side, he couldn't move at all. And he wasn't opening his eyes at all, and he wasn't communicating or interacting verbally at all. So his GCS was a 7, and you think that mechanism of injury, as you can see here, this is the, with my cursor here, this is the skull, the bone, the white is the bone, and you can see over here on his right side, this is how it should look, a nice, oh sorry, I accidentally clicked there. Sort of nice normal contour of the skull, but then over here you can see that's disrupted. So this skull should be connected right here, but you can see there's that gap. And so here you can see he actually had an open skull fracture, and there was actually brain tissue that had sort of extruded outside of the skin and the skull. So he had exposed brain, which is always concerning and problematic. And just knowing that mechanism, it was definitely a severe TBI. He had a large left parietal lobe bleed. So you can see here, this white stuff inside the brain tissue over here is blood. So there was a large bleed on the left side of his brain, and this was causing sort of mass effect and herniation. So that large bleed was pushing the brain tissue out. Herniation means basically pushing it out of the holes of the skull into places where it doesn't belong. And when it herniates, it can cause even death. If the brainstem herniates through the base of the skull, that can kill people for sure. So it was a very concerning injury, but it was also sort of a mixed picture because he was moving the left side of his body, but not able to communicate or interact or open his eyes at all. So it was sort of a mixed picture, but very clearly a severe TBI. He underwent decompressive craniotomy, so they opened him up and took out that blood that was causing that pressure and pushing on the brain to cause the herniation. Couldn't get an MRI on his brain because he had an old bullet fragment in the pelvis. And so his neuro exam 2 days later, 2 days after arrival and after the decompressive craniotomy, he still was moving that left side of his body. His eyes were still not, 1 is the lowest score you can get, so he had a 1 for the eye opening, and that's the worst you can do. He still was not opening his eyes, even to painful stimuli, but he was still moving the left side of his body. And we couldn't tell about verbal because he was intubated, so he couldn't actually speak, but didn't seem to have any attempts at communicating from what we knew. His pupils were 3 millimeters and were reactive, and he did again move to pain. The left side of his body, he would move it and spontaneously move the left arm and leg as well. I'm mentioning here is intracranial pressure. So intracranial pressure is something that's monitored to assess severity of brain injury, and we'll talk about it more as we go on in the talk. but I just wanted to mention sort of his ICPs or intracranial pressures were sort of in the 10 to 20s range for that period of time. Hadn't really gone up above the mid-20s. So now I wanted to talk about, having sort of introduced those two cases, just reminding us what severe TBI is and looks like. What are clinical outcome measures that we use? So as clinicians, we sort of get information from research studies that sort of informs our opinion along with our clinical experience, right? So we kind of put all of that together to make our opinions and things we discuss with the family. So that's kind of what I want to go through the rest of the talk, talking about what do we know about these types of brain injuries? And so a lot of it comes from research, and the clinical outcome measures that have been used the most in research to describe these types of injuries and recoveries are things like the disability rating scale, the Coma recovery scale, and the Glasgow outcome scale. And we're going to go through each of those in more detail. And really what these are doing is trying to give you a sense of really what is the outcome like for this patient. And I'm talking here about sort of a good versus a poor outcome. And it's really, is this going to be a good outcome or a bad outcome, right? And there's lots of ways, we're going to go through this in more detail, but there's lots of ways you can define what is a good outcome and what is a bad outcome. And it's challenging, as you can imagine, in a research setting and also in a clinical setting. So life and death is one potential outcome. Are they going to survive? And then looking at what is their quality of life and their level of their disability. So a lot of the outcome measures basically look at trying to predict or prognosticate, are they going to survive this injury or not? And how disabled are they going to be from it? Is it going to be a good quality of life or not? And that's kind of what you want to be able to tell people in those early days after brain injury. So one of the scales that's used to help figure this out is the disability rating scale. And this is used in older juveniles and adults with moderate to severe TBI. And it can track progress from coma to community. And looking at their level of disability, their feeding, toileting, and grooming, and their level of functioning and employability. So whether they can get back to working and living independently. A score of 0 means there's no disability, and a 29 equals an extreme or prolonged vegetative state. So the Coma recovery scale, this one is initially described by Giacchino and his colleagues in 1991 and revised again in 2004. So this one's been around for a long time. We've got sort of 3 decades of experience with the Coma recovery scale. It's very useful. It has different subscales of auditory, visual, motor, oral motor, and communication and arousal. And it's also useful in assessing progress in disorders of consciousness patients from that sort of coma to community level. And the Coma recovery scale is actually a really useful scale clinically, because it can be really beneficial when you have patients who have severe TBI and are in sort of a rehab program specifically for disorders of consciousness to try and help them emerge from coma to vegetative state to minimally conscious state. Programs that describe and define their progress on the Coma recovery scale can be really useful to help demonstrate progress that, okay, they are improving. They're not improving on functionality like you would expect from a functional independence measure or a FIM at an acute rehab level of care, because they don't have enough function to be able to do that. But using the CRS can show you, yes, their numbers are improving on the CRS. They're improving from coma to minimally conscious state, and that can justify spending additional time at a disorders of consciousness rehab program. This is just a picture of what the Coma recovery scale looks like. I'm not going to go through each item, but and Paige, do we have our poll question now, or is it in a minute?
In another minute, I'll tell you when.
Perfect. So the Coma recovery scale has the looking at auditory function, basically how well are they listening and hearing to things. Same with visual function, how well are they tracking objects? Are they able to visually recognize objects, reaching for them? The motor scale, how well are they moving their body? Their oromotor, how well is their mouth moving and communicating? And how are they doing with arousal? Are their eyes open or not? Are they attending or not? And then here we have the Glasgow outcome scale. So again, to differentiate from the Glasgow Coma scale, which we talked about early on, looks at how severe is the coma for a patient. The Glasgow outcome scale is a global scale of functional outcomes. So it's how do they look in terms of their level of disability and independent functioning. It's used in research studies to quantify outcomes. And the challenge of this is when you're looking at research, and typically statistics are involved, and there's a mathematical equations that have to be determined to come up with basically a good versus a bad outcome. And this can be really hard because you have to sort of figure out, well, how do you define good versus bad? And really what this comes down to when you're in their room with a patient in an ICU setting in early days after severe TBI, when you're talking about the outcome, the conversations that are had are things like, whether or not you want to continue life support for these patients, whether you want to continue all the life-sustaining measures or withdraw life support. And so it's really an issue of life or death, and how we discuss this with the patients really matters in those early days. And we have to think about sort of not only our own perceptions of what is a good and a bad quality of life, but also open up our minds to thinking of, well, what is the family's measure of good versus bad outcome? And I'll go through a little bit more of the Glasgow outcome scale. So what it is, it's technically a structured interview, and it's just asking questions of the patient if they're able to communicate, or the family member and caregiver most of the time. Things like, are they able to obey simple commands or say any words? Do they need another person's assistance for essential activities of daily living? Are they able to shop for themselves, travel locally without assistance? Are they able to work or care for family members? Do they have any work restrictions? Do they have social and leisure activities outside of the home? And has there been any disruption in relationships due to psychological problems? It just gives you an idea of what kinds of things are asked in this Glasgow outcome scale. This is the extended version. And Paige, I'm forgetting, am I supposed to go through these first before the next poll question?
Yes, you can
Okay.
keep going.
Okay, thank you. So here we have the Glasgow outcome scale extended, and this is basically the results you get. So you go through the structured interview, you have all these questions, and you get a number score. And they are divided into these different categories. So the worst being death, vegetative state, and then they have a lower severe disability and an upper severe disability, a lower moderate disability and an upper moderate disability, a lower good recovery and an upper good recovery, right? So these are sort of the categories that you get after you've done the structured interview. They sort of get categorized into these different levels of disability. So sort of how severely disabled are they? How independent are they? How disabled are they? Is sort of what this scale reports. But the real question for me as a clinician and trying to incorporate all of this information is, where do you draw the line and sort of defining what is that good outcome and what is that bad outcome when we're talking about, okay, what is life going to look like for this person down the road after the severe TBI? Is it defined by a good recovery versus any amount of disability? And for example, I've had some patients whose family members have told me, he was struggling. My brother was struggling before this. He had mental health issues. He was barely functioning. He was suicidal at times. He was coping horribly with all of his challenges in his life. And if he had any level of disability on that, any level of disability added on top of that, he wouldn't want to continue. He wouldn't want to continue having all these life-saving measures, and they wanted to withdraw care. So for some people, and I've had other family members where they're said, my mother was just so independent. If she had to have a caregiver come in the home, that would be worse than death to her. If she had to have somebody come in the home and be in her house taking care of her, she would rather die. So for some people, the line would be drawn here, where sort of between good recovery and any amount of disability. But then you get to the question, well, how much disability is acceptable? So for some people, a moderate amount of disability would be fine. Like they'd be okay if as long as they could be aware and it could have some enjoyment of being conscious and being aware of being near their family and their loved ones and spending time together as a family. That would be enough for them, even if they needed help with things, couldn't get back to working, couldn't live independently, but could appreciate time with family. For some people, that's enough. And for some people, you wonder, is just being alive enough? Even if they're in a persistent vegetative state, I've had families who say, I don't care. I know his spirit's still there. If he's alive, I want to care for him. I had, I'm going to back up to this one because I wanted to tell you guys about this one woman. Family, their husband was brain injured, and the wife was incredible. She had said to me when I was talking with her in ICU in sort of the early weeks after his brain injury, she said to me, that the surgeons told me he's got 10% chance, or he's going to be 10% the man he was before. And, we kind of looked at each other, not really knowing what does that mean, right? If somebody says, you've got this 10% chance, it's like, well, what does that mean? And what she looked me in the eyes and she said, if he is 10% the man of who he was before, I want him, and I'll take care of him, and I'll do whatever I need to do to have him home with me, and I'll learn. And they were in their 70s, mind you, and she did, and he was in this sort of probably somewhere between upper severe disability and lower moderate disability. But she was there every day with him in rehab. She learned how to transfer him. She learned how to feed him through his feeding tube. She learned how to clean his bottom. She learned everything he needed and took him home. And she was happy and he was happy, and they were really pleased with that outcome. But I've had other family members who say, just being alive is enough, that I don't care if they're in persistent vegetative state, that if they're alive, then we'll take them home and we want to care for them. And that's all that matters to us, is that our loved one is still alive. And I think culturally it's interesting because in the United States, there tends to be a bias towards sort of disabled life and living with any amount of disability, let alone a persistent vegetative state. And a lot of people in our countries tend to not value someone's life if they are in a persistent vegetative state. But for example, one of the conferences I attended spoke about care in India, and that at least at that time, they had, in India, they didn't really have withdrawal of care. There really wasn't an option or a discussion to be had in terms of withdrawing care. If they lived, the family would take them home and care for them. And so there wasn't really this discussion because it wasn't thought of at all that you might withdraw care in that type of a situation. So it's really just a matter of having to have these individualized discussions with the family members and figuring out where is their value and what is important to them as a family, but also really trying to get them to see what would their loved one who can't speak for themselves tell us. If they could tell us what to do in this situation, what would they want? And it's hard, they're hard conversations, but that's really what you need to sort of figure out, is how to have that conversation about where in this level of recovery is acceptable. Now, the problem is, even once we know what is sort of an acceptable outcome for a family, it's really hard to predict with great accuracy, especially early on, what the future is actually going to look like. And that's really the challenge. We don't have a lot of good tools or good prognostic markers in the early days to weeks after brain injury to really be able to say, okay, clearly they're going to have this much level of disability down the road. And that's really the challenge with prognosis in severe TBI, is that we don't have great prognostic indicators. The things that are used are from a research standpoint, are things called the crash and the impact models, and I'm going to show you them. So the crash model is a corticosteroid randomization after significant head injury. That's how they got crashed. And really what this does is it predicts unfavorable outcomes. So again, bad outcome at 6 months and mortality at 14 days. So are they likely to survive this injury, and are they likely to have a good or bad outcome? And it looks at things like the basic model is just age, initial GCS, whether the pupils are reactive or not, and whether there's a major extracranial injury. Then there's another layer to it that can add in the CT model, where you actually add in imaging findings. It includes all of the basic model variables, but then also classification of severity of injury in terms of CT findings and whether there's a traumatic subarachnoid hemorrhage. So the impact model, similar to the crash model, but it's the International Mission on Prognosis and Analysis of Clinical Trials in TBI. And this is also used for predicting unfavorable outcome and mortality at 6 months after. And this one includes looking at things like the clinical factors like the age, GCS, and pupils, the extended model with those plus CT findings, whether there's any hypoxia or low blood pressure, and then looking at lab findings as well. So trying to add more variables in to get a better, more reliable prognostic factor. The challenge, though, is they both are only about, if you round up all these numbers, they're about 75% accurate. So that means that when you plug in all the numbers on these and they say someone's likely to die or likely to have a bad outcome, they're only right about 75% of the time. So for both the crash and the impact, even when they added all those extra features, it didn't really improve the accuracy of those predictions of those two studies, of those two models.
Okay, Dr. Spalding, this is where we'll stop for the second poll question. So I'll
Here's
launch
our
that now.
Second poll question. So if you guys want your credit, you can ask this. So which scale or scales, there's technically 2 right answers here. So you can choose either of the 2 right answers, which can reflect functional progress from coma to community. And it's you guys are getting it right. It's really the Glasgow outcome scale and the coma recovery scale can really be used to look at patients as they're recovering from their comas. And the Glasgow coma scale is the one that really just looks at initial severity of injury. And the crash impact are meant to be sort of prognostic tools that are helpful but not very accurate.
Okay, we'll give it about 5 more seconds.
Perfect. If anyone else needs to put in a last minute answer for those CE credits, feel free.
Alrighty.
Okay, great. So I'm just going to go back to and show, oh, sorry, clicked again, showing you how one might utilize that crash and impact models. So this is our initial gentleman who was the 31-year-old who had the big rig wheel blow up and hit him in the face across the freeway divide. And I forgot to mention it was Valentine's Day, the day that he was hit. But he, just to remind you guys, so he had clinically what was going on with him. So over the few days, this is now 5 days after injury, you can see here that he had a craniectomy. So they took out the skull on the left side of his brain. And as you may or may not be able to tell, all of this tissue that's all the same color here, that's his brain. So his brain is swollen very extensively outside the skull. You can see that, and there you really can't see the grooves or the sulci that you normally would see here because it's just so swollen. He had extensive bifrontal and bitemporal hemorrhagic contusion, so bleeding within the brain, large gross bleeding that could be seen on CT scans. You didn't need to do the MRI to know. He had bilateral subdurals and subarachnoids, and then this severe edema with herniations. They were actually worried that he might not even be perfusing his brain because there was so much pressure, so much swelling. They were worried that blood couldn't even flow into his brain because of this. And I just wanted to show you, we're not going to go through each line of this, but I just wanted to give you an idea of what the crash and impact looks like. So I took his data and I sort of plugged in that these are the impact results. So what you can see here, all of these sort of red percentages are what the impact model would give you a percent of having either death or a bad outcome. And I couldn't see his eyes because his face, because he had the facial fractures as well, his eyes were swollen shut. So I couldn't even open his eyes to know whether his pupils were reacting or not. But I did it, so I did it in both versions. So if his pupils were not reactive, it showed sort of 64 to 86% chance of mortality or unfavorable outcome. And if his pupils were reactive, then that would be more like 34 to 77%, depending on all of these different factors, right? But just think about like how is this actually useful as a clinician, and sort of early on, like when you have this kind of sort of statistical data, right? It's hard to take this and translate that into something useful and meaningful in terms of a bedside conversation with a family about what to do in this situation and what are they expecting and what does the road of recovery look like after these types of injuries. So there's some studies on clinical judgments. We have the research studies, look at all these variables, and then, they wanted to sort of figure out, well, do doctors actually know any better than what these research studies can tell us, right? Can doctors predict when a doctor is saying, okay, I think this is going to be a bad outcome, or I think this patient's going to die based on this injury? Is that accurate or not, right? And so this was done out of shock trauma at University of Maryland, and they compared the crash and impact predictions versus an experienced clinician assessment. So asking them whether or not they thought the patient was going to die from this injury, and whether or not they thought they were going to have a poor outcome at 6 months. And they were all older than age 14, and they all had initial GCS level less than or equal to 12, so moderate and severe were in this category. And they surveyed 3 groups. So nurses, and these were emergency room and ICU nurses, physicians, again, emergency room and ICU physicians, and then neurosurgeons. They differentiated neurosurgeons from other physicians. They asked them at day 0, so the day of arrival, day 3, and day 7. What they found was that, so for the crash and impact predictions were sort of accurate. Again, this is the accuracy of whether those predictions came true or not, was about sort of mid-70s to up to 80%. Better likelihood of predicting death than long-term disability from these injuries. And if you look at it the other way around, they were inaccurate about 15% of the time for mortality predictions. So that means they say, I think this person's going to die from this injury. About 15% of the time they were wrong. And about 25% they were wrong about 25% of the time for saying this, I think this patient's going to have a bad outcome. And that is incredibly important, because you think, well, 1 out of 4 patients who I take all the clinical information I'm putting together, and 1 out of 4 times I'm wrong when I say I think this person's going to have a bad outcome from this type of an injury. And those are not great odds. It's not odds I would really want when I'm making life or death decisions, right? To be wrong 1 out of 4 times. Physiatrists like myself, brain injury physicians, were not included in the MD opinion group, but I'd argue, how could we do any better? We don't have any way to know with all the information we can get out of these patients in those early days. There's really no tool that can give us an accurate prediction of what life is going to look like for this person down the road. Do we have our third poll question now?
Yes, I'll launch that now.
So here's our third question. And how often are clinicians wrong? And I made this our question because I think this is like one of the most important slides for me in this whole talk. Is that I think as physicians, we often feel like we're infallible and that our opinions are accurate, right? But we have to know when we're saying things early on, we don't always know. We can't always predict with great accuracy. And so when you're having these conversations in the ICU, it's almost, I think of it almost as like informed consent. You know, I have to tell people, I don't have enough information to really know for sure. It doesn't look good to me. It looks really like this is a really bad brain injury that's likely to have a bad outcome. but this early on, I don't know with any great accuracy for sure what the future is going to look like. And it's hard to have these conversations early on. I want to give just a few more seconds because I know we had 84% voted on the other one. So in case anyone else wants to get another vote in there. All right, I think we got all our votes now.
Alrighty.
Yeah, so the answer is 25%. 1 out of 4 times we're wrong. We don't know, and in the early first week after injury. So what do we know? We do know some things make things worse. We do know if certain things are going on, it's likely to make a worse outcome. Low blood pressure. If the blood pressure is low in the field, if it's low when they arrive, if they're having to work really hard to keep their blood pressure up in the ICU, we know that's bad. We know elevated intracranial pressure is bad. If there's high pressure inside the brain, in those days after in the ICU when they're monitoring the intracranial pressure, above 20, if anytime it goes above 20, that adds sort of cumulative disability to it. If it goes above 30, that's even worse. And so you want to sort of looking at incorporating, well, how long have they been going up above 20? How often are they going above 30? And that kind of weighs into your thinking of, well, okay, this is looking like this is going to be more likely to be a bad outcome. Hyperthermia. Each fever corresponds with a worse outcome. Each time they have a fever, they that results in more disability. And so they work with cooling blankets to keep them cool, to keep their temperature down, work with antipyretics to keep the fevers down, because they know that every time they get hot, it causes disability. And if there's a comorbid anoxia or hypoxia, again, those things I talked about earlier on, prolonged time to resuscitation, if they've lost blood, if they're not perfusing well because of cardiac malfunction or low blood pressure, then that causes further insult to the brain. That's likely to lead to a worse prognosis. And the severity of the imaging abnormalities. So how much swelling there is, like the man with the big rig wheel, that looks really bad. That's definitely not promising for any kind of good outcome there. So back to him. So he had been sedated. His intracranial pressure was being monitored. When the pressure goes high, basically there's a limited amount of space in the brain, right? You can take the bone off and let that will often help because they can swell out of the brain and give you more space. But even after his craniectomy, he still had high intracranial pressures. As the brain starts to swell, it pushes all the fluid out, the CSF, the cerebrospinal fluid. They tried to drain some out with an extraventricular drain to get some of the fluid out to make more room for the brain, so there's less pressure on the brain itself. But he still had ICPs up into the 20s and the 30s for the week, the whole week after the injury, even after the craniectomy was still spiking. I did all the things they could do to try and lower his intracranial pressure, like sedating him, using hypertonic saline, draining it, paralyzing him with the neuromuscular blockade, draining the CSF out of not only the brain, but also from the lumbar areas, trying to decrease that pressure. And they really couldn't get it down. He kept swelling, kept herniating. So this is now a week after he arrives, and we had a family meeting. So the trauma surgeons were there, a neurosurgeon was there, and I was there. And we discussed prognosis with the fiance, and his parents were there. And I think all of us felt very clearly that he really did not have a good chance for functional recovery. Because again, all of those factors above and beyond sort of the things you would find in the crash and impact model, right? And the family did make a decision to withdraw care. The next day, he was extubated and pronounced dead. His fiance was in the room with him when he died, and they decided to donate his organs and had 2 successful donors so received his organs. So the family was very thankful for that after his liver and his kidneys were harvested. So it was a heartbreaking situation, but I think we all felt like it was very clearly going to have that bad outcome, if not about to die because of those imminent herniations that were already happening. So I think we all felt very clear that that was the way to counsel the family, that he was expected to have those outcomes. But again, it's that first week. And so I always have in the back of my mind this little bit of pause of like, do we really know? But I think in that case, we all felt very confident that it was appropriate to counsel that to expect long-term disability. And family was very clear that if he was going to have any long-term disability, he would not want that. And so everyone felt comfortable with that decision. So if we don't know in the first week, when do we actually know anything useful and reliable and accurate in terms of predicting with severe brain injury? The timeframes that we do know is that a severe disability, according to that Glasgow outcome scale, those severe disability categories, unlikely when the time to follow commands is less than 2 weeks. So if someone wakes up, starts following commands like give me a thumbs up, show me 2 fingers, move your left leg, touch your nose, if they start doing those kinds of things within 2 weeks, then it's really unlikely that they're going to have a severe disability. Or when the duration of post-traumatic amnesia is less than 2 months. So if someone's not following commands by 2 months, or by 2 weeks, but is still in PTA, you might not know for the really 2 month time, like whether or not they're likely to have that ongoing severe disability with really good accuracy in those predictions. And on the other side, so a good recovery is unlikely. So when can we really say with great accuracy that we think a good recovery? And again, knowing that that good versus bad comes with judgment and different ideas about what is good and bad, but a good recovery is unlikely when time to follow commands is longer than a month. So if it takes them more than a month to follow commands, then getting into that good recovery category on GOS. Or duration of post-traumatic amnesia is greater than 3 months. If they're older than 65, or if the MRI is done and shows bilateral brainstem injury, then it's really unlikely that they're going to have a good recovery. But it's all about counseling and figuring out, well, what is considered a good recovery for this person, not according to the Glasgow outcome scale, it's good recovery. But it really takes about 2 months before you can really say with really great certainty, but it's hard to wait that long to have these sort of withdrawal of care decisions and discussions, because some people don't want to put their loved one through it for that much longer. And they say, I want to decide, I want to make this decision now. And I think they wouldn't want this and we need to stop. And so I've definitely had those conversations that where I've sort of had trying to move slowly and take time. And the brother was just like, the one with the mental health and who didn't have, was struggling beforehand. And he said, no, we need to, let's stop this now. Like, can we get palliative care in here right now and be done? Because he would not want any more of this. So it's challenging work and it's hard work. And it takes time to really know anything. So just to say briefly, in Prognosis Studies, there's really this growing body of research that looks at longer term outcome studies. So looking at a year, 2, 5 years after injury, and about 20% of patients who are in sort of prolonged vegetative state or minimally conscious state, meaning they're still in that state for a number of weeks, they can still achieve functional independence 1 year after injury. So about 1 out of 5, even if they look like they're still in vegetative state or minimally conscious state weeks after injury, about 1/5 of them can still have an independent future. So it's just important to keep that in the back of our mind. We tend to have this sort of negative perspective of life with disability, first of all, and then recovery from these severe brain injuries, what their chances are. But it's important to know that there can still be that chance for independence. And then this is, again, I've talked about this on the prior webinars, but I have to say it again because it's so important. That there was a study done on TBI mortality and looking at 6 different trauma centers across Canada. Basically, to summarize all that data, what they really found was that depending on the trauma center, they were more or less likely to withdraw care in those early days. The first 3 days, about half of the deaths were due to withdrawal of care in those first 3 days. In centers that tended to withdraw care, up to 86% died due to withdrawal of care. And the incidence of withdrawal of care really mattered depending on which trauma center you were in. And I think that has to do with how well versed the clinicians are, the physicians are, in having these conversations. You can imagine as a family member, if a surgeon, a trauma surgeon, or a neurosurgeon comes in and tells you, you know, your loved one is going to be disabled for the rest of their life. They're not going to be able to feed themselves. They're going to need to eat out of a feeding tube. They're not going to be able to wipe themselves. They're not going to be able to talk or move. You're going to have to transfer them in a wheelchair, or they'll be in a bed for the rest of their life. Would you want to continue this life? Would they want us to continue doing everything we're doing or not? Right? And you can imagine how you have that conversation in a very vulnerable family member, and when they're going through this, it can really sway their decisions. And there's guidelines. So there's some trauma centers actually participate in the Brain Trauma Foundation guidelines. They found that these in-hospital guidelines actually result in less time in the ICU, less healthcare costs overall, decreased death and disability by 30 to 50%, and improved neurological outcome. And these are all things these guidelines are not in terms of prognosis per se, but in terms of how to care for patients with these. And it's really important that we do everything we can from a care system perspective to help these patients get to centers that know how to care for their brain injuries, both in terms of how to help keep them alive, how to decrease their disability by decreasing the complications that happen from fevers, from intracranial pressure elevations, from low blood pressure, and how to have the conversations with them about what the future looks like with this type of an injury. So anything we can do from a system standpoint to help connect them with the right kind of providers, the right kind of centers, is incredibly useful. So just to go back to my my logger, so this is 3 days now, 3 days after admission. Again, family meeting was held with neurosurgeons, pulmonary and critical care was involved in trauma, and me were there. We again talked about prognosis, and this was one that it was honestly harder for me, because, you know, his findings weren't as bad as the other gentleman. He was moving the left side of his body. It was like, you know, I don't know, and it's day 3. I don't know what the future really holds for this man. But we talked about it, and neurosurgery and the critical care doctors were more confident that he was likely to have a bad outcome, because to a 1,000-pound piece of equipment just crashed into his skull. The surgeon had seen his brain on the outside of his body, right? They felt this was incredibly severe because of those factors. And the family did decide to withdraw care. But again, it was one that really gave me pause, because I just wondered, you know, I wondered what would life have been like, and did I counsel them well enough, and did I give them enough information to really help make an informed decision, you know, on day 4 of the hospital stay, right? And I don't know, you know, to this day, I don't know, because we did choose to withdraw care, right? So we sometimes make our own outcomes because of how we counsel people. And the family was very clear that he was independent and he would not want any kind of disability whatsoever. That would not be an acceptable outcome to him. But also, we do know that people's perspectives change with time. And after they've had their disability, they have a spinal cord injury, they have a brain injury, they're now willing to accept and find a good quality of life, even with this disability they previously perceived as being an unacceptable quality of life. So we just have to open our eyes and our minds to how we think of these things. And just think about how we can protect these patients who are very vulnerable because they can't communicate for themselves, they don't understand, and we're relying on their family member and the treating physicians to inform them appropriately. So it's just incredibly important work, and I think a lot more needs to be done in terms of education on the physician side. But I thank you guys for spending the time with me, so we can start having the education on our side of things from the systems perspective as well, because that can help to make sure that these patients get the care that they need early on. And I know I only have like 1 minute for questions. I can stay for as long as we need to, and we can also work on, if there's a lot of questions, we can write up responses and email them out, because I'm sure you guys are busy and have things to do. So if anybody needs to leave, I know, feel free, and if there's any questions, we'll go through them.
Thank you, Dr. Spalding. 2 questions have come in so far, so we'll start with those. The first is, did the patient have advance directive? And I believe that was geared toward the 31-year-old patient.
No, he didn't. He didn't have one. And I think a lot of, younger people especially don't think that way and don't have one in place. Neither one of the cases who I presented did have one, in fact. But it's important because I think it's something to encourage, young people, especially when you have families and other things, to get those, because having that in place really is helpful. Not only in terms of helping to know what that person would have wanted, but also designating the decision maker when you're absent is incredibly important, because if you don't have that document to then decide who's going to be making those decisions, it can get really complicated. And we've had patients had to go to, or family members had to go to court to be designated a conservator to be able to make some decisions if there was a disagreement in the family, for example. It can be really challenging.
Thank you. Okay, the next question is the Canadian model example of decision-making likely from socialized medicine reduction of cost concerns long-term?
I don't know. They didn't speak to that in the article. I think that's a question, and I think that's part of, we have to think about what are the biases of the physicians who are counseling the family members in these situations, right? And is one of them, part of what I was tasked with when I was working at UC Davis was to move patients through the healthcare system, to get the patients out and get beds open. And so there's pressures that people have from all different sides of things. And you have to think about, well, how is that affecting how the clinicians are counseling the patients in that setting, right? So definitely the ideas of cost containment. When you have patients who are in prolonged vegetative state in an ICU bed for 3 months, 4 months, it's very costly to the system. And so that does weigh on people's minds. But I think you have to have the conversation with the family member without taking that cost perspective into it, and just thinking about, well, what is the best information I can give this person on what I think the future is like for this loved one. And what I honestly do in these conversations is I say early on in those first days, even to a couple weeks after, I say I don't know what the end of this road of recovery is going to look like. I know it's going to be a long road, and I know it's going to be a hard road, but at this point in time, I still don't know. And some people can say, they wouldn't want to do any of that, and can make those decisions early on with confidence, and the family members can. And some people say, we just need more time. We need to see. I have a patient right now who I'm caring for who's still in minimally conscious state, a year and a few months after injury, and she's like, I just want to give him a little more time just to see what his recovery is going to look like. What is this end of this road for him? She's still debating whether or not to withdraw care, but he's not intubated, but he does have a feeding tube. And so she's still deciding in her own mind, what do I do? And so I see it my role as the clinician to just offer support, guidance, education as I can, and help the families with these incredibly challenging decisions.
Awesome, thank you. A couple more questions. The next is, I have a claimant with DIA, and he had spontaneous talking one day. He usually doesn't talk, just repeats things. My question is, how rare is that?
Yeah, it's rare. So, typically with brain injury, what you see is that in terms of recovery, that they will, they'll get better and improve, and then they'll sort of plateau at some stage down. But typically from day to day, you'll see the same level of functioning, but sometimes they have the perfect storm of, they've got the right medications on board, they're not too sedated, they have enough neurostimulant on board, they've gotten enough sleep the night before, and then they have 10 minutes of incredibly good alertness, participation, communication, and then they fatigue and it's gone. And so sometimes they have just these little glimpses of like, I can do this for just this littlest bit of time. And if they start to be able to do that, then that's a good sign that they can start doing more of that in the future, that there's chances for more recovery to happen. But, and I'm not sure if I understood the question completely. So if there's anything I can clarify on that, either from your reading of it, Paige, or if you want to write anything else about a new question, whoever wrote it.
Okay, thank you. Next is, are there legal or ethical considerations, are there legal or ethical considerations of possibly missing windows to withdraw care? For example, if the patient ultimately can breathe on their own, but they're very disabled and they have a very low quality of life, and then how do you counsel and manage that?
Yeah, it's hard. It's hard. And I've had patients who have been, 3 years out from injury, and family didn't want to withdraw care. And it's usually in these situations, it's because there's a difference of opinions. For example, the parent wants to continue care, and the wife thinks it's appropriate to withdraw care. I had a patient who was very clearly in a persistent vegetative state, and the family, the parents wanted to continue everything for a long time. And so I think from my perspective, I'm open with people early on, and I say, it can be harder to make these decisions once we put in a feeding tube. For example, it's harder to think about, well, taking away a feeding tube than to never put it in, right? And so in having these conversations early on, I let families know that, I don't know what's going on. Once you put this in, do it with the mentality that this isn't permanent. It's a support that I'm doing for now because I think that my loved one would want to continue all of these efforts for some more amount of time. And knowing that it's, once you do it, it doesn't have to stay in forever. If you get to a point of time where you feel like, okay, this is enough, that my loved one does not have the outcome that they would want. They would not want to continue living in a persistent vegetative state, for example. That it's something that can be changed later on. And so it's all about how you have that conversation versus if you go in there and say, 3 years later, say, oh, all of a sudden now you don't want to feed your loved one anymore. Like I've had nurses who've said to families, or to me, questioning, why are you pulling the tube now 3 years later? We're starving this person, right? And I say, no, this person has a terminal condition. They have a brain injury with dysphagia where they don't eat and they can't swallow safely on their own. If we don't continue these life-prolonging measures of supplemental feeding, they're going to die. It's us who put them in this position, and it's hard. It's hard for the nurses. It's hard for family. It's hard for the therapists who've grown attached to these people over time. And it's incredibly hard, but I think it's a matter of just being open and communicating about it the best we can throughout the whole process, to really have it sort of be done well and comfortably so that everybody feels not good about the decision, but feels like it's the right thing to do. I think it takes a lot of talking and a lot of understanding and questioning and learning about each other and what they would want and what their families would want.
Okay, great. Thank you. That looks like that is all the questions for now. I will just quickly mention that if you sent a specific question about documentation or anything pertaining to the CEs, I will reach out to you directly on email. Just as it's easier to handle it that way. And in the post-session follow-up email, you will get a survey with one simple question, just asking if there's any topics that you would like to hear about from Dr. Spalding in future sessions. Just please submit them there, and we'll do our best to get you that info in a future session. So I think that's it.
Yeah, thanks again for taking your time to listen to this topic. I think it's incredibly important, and there's a lot more work to be done on it, but I really appreciate you for taking the time to listen. Thank you.
Thanks, everyone. Have a great day.